Hello and welcome back to the deep dive. I have to say, looking at the stack of research we have for today, I'm seeing the world a little differently.
Ah,
Specifically, I'm looking at the double doors of the emergency room with a whole new level of respect and maybe a little bit of fear.
I think that's a healthy response.
We usually think of the ER as this place of, organized chaos, right? Beeping monitors, gurneys rushing by.
Hmm.
But when you dig into the literature on today's topic, it feels less like a hospital and more like a high-stakes poker table where the house almost always wins.
Unless you know exactly how to count the cards.
Exactly.
That is a terrifyingly accurate analogy. And honestly, for an emergency physician, the topic we are discussing today, chest pain, is the ultimate high-stakes hand. You cannot fold.
You have to play.
You have to play every single deal. And you know that while most hands are a bluff, one of them is a royal flush that will kill the player sitting across from you.
And the numbers, they just back that intensity up completely. I was looking at the epidemiology data we pulled, and chest pain accounts for something massive, like 8 to 10% of all ER visits.
Annually, yeah.
In the U.S. alone, that's millions of people. Every single year.
Is the bread and butter of emergency medicine.
But here's the cruel joke of biology. For the vast majority of those millions of people, it's nothing.
Right.
It's the spicy food from last night. It's a pulled muscle from lifting a grandkid. It's a panic attack. It's benign.
We call that the noise.
Exactly, it's noise. But hiding in that noise are these silent, rapid killers. And we aren't talking about the benign stuff today. We are not talking about heartburn.
No.
We are talking about the monsters that look exactly like heartburn until they stop your heart.
We're talking about the needle in the haystack. And specifically, we're honing in on the one needle that is notoriously the hardest to find.
Right.
Everyone knows about heart attacks.
Yeah.
Everyone has heard of blood clots in the lungs.
Yeah.
But today, we're talking about the third player in the big three.
The aortic disasters.
The aortic disasters. Acute aortic syndrome.
AA.
It's the diagnosis that keeps seasoned doctors up at night because it is a master of disguise. And the mortality statistics you saw, they're sobering.
Sobering is a polite way to put it. I read the stat for type A aortic dissection, which is the big one we'll get into, and I had to reread it to make sure it wasn't a typo.
It's hard to believe, isn't it?
The mortality rate increases by 1 to 2% per hour.
Per hour. For the first 48 hours, if it's left untreated.
That's insane.
Think about what that means in practice. You walk into a busy ER on a Tuesday night. You wait 3 hours to be seen because the waiting room is packed.
Uh-huh.
You wait another 2 hours for labs. By the time someone realizes what's wrong, your risk of dying has statistically jumped by maybe 10%.
Just from waiting.
Just from waiting. Speed is absolutely everything here.
So that really sets our mission for this deep dive. We are going to figure out how clinicians catch this thing before the clock runs out. And what I found fascinating in these papers is that it's not just about, throwing every single person into a CT scanner.
Right, because that's not feasible or safe.
Way too much radiation. We're going to look at how they're using some really clever detective work. Specifically, a blood test I thought was only for clots called D-dimer. And a new mathematical ratio that seems almost too simple to work but might just be a lifesaver.
It's a classic example of using old tools in a new way to solve a really complex puzzle. But before we get to the math, we have to understand the anatomy, because acute aortic syndrome isn't just one thing, is it?
No, and this was my first learning curve. I always thought aortic dissection was the only issue. But looking at the literature, AAS is actually an umbrella term. It's like a family of 3 siblings.
Exactly. They're siblings because they all attack the aorta.
Yeah.
And you have to remember the aorta is the main highway carrying high-pressure blood from your heart to the rest of your body.
The trunk of the tree.
It's the trunk of the tree. If that highway fails, the whole bridge collapses.
So let's meet the family. The big one, the famous one, is acute aortic dissection, or AAD.
Correct. This makes up the lion's share, about 70 to 80% of these cases. And to understand it, you have to visualize the aorta not as a simple PVC pipe, but as a tire. It has layers.
Okay.
The inner layer, in contact with the blood, is the intima. In a dissection, you get a tear in that lining.
And because the blood is under such high pressure, coming right out of the heart, it doesn't just leak, it blasts through that tear.
It creates a hydraulic wedge. Blood forces its way into the middle layer of the wall, the media, and it literally rips the wall apart, separating the layers.
So now you have 2 channels.
Exactly. You have the true lumen, the actual pipe where blood should be, and a false lumen, a new channel forming inside the wall of the artery itself.
That sounds structurally catastrophic.
It is. That false lumen can spiral down the entire length of the aorta. It can crush the true lumen, so organs, kidneys, liver, even the brain don't get blood. Or, worst case, it bursts through the outer wall, the adventitia, and you bleed out internally in seconds. Game over.
Okay, so that's the violent sibling, the one that rips. What about the second one, the intramural hematoma, or IMH?
This one is a bit more subtle, but just as dangerous. It accounts for maybe 5 to 25% of cases. With IMH, you don't necessarily have that clear primary tear in the inner lining. The blood isn't rushing in from the main channel.
So where does the blood come from?
It comes from within the wall itself. The aortic wall is thick, right? It needs its own blood supply to stay alive. These are tiny little vessels called the vasa vasorum.
Literally vessels of the vessels.
Right. In IMH, these tiny vessels spontaneously rupture.
So you're bleeding inside the wall of the pipe.
Exactly. It's like a massive bruise forming within the layers of the aorta. There's no flap, no tear initially, but the wall is compromised. It's structurally weak.
And the danger is that this bruise could evolve.
It can weaken the wall enough that it eventually does tear, turning into a full-blown dissection or a rupture.
So it's a precursor or a variant. And then the third sibling, the penetrating aortic ulcer, or PAU. This sounds painful just saying it.
This one is usually a disease of older patients with bad atherosclerosis, hardening of the arteries. Imagine a plaque on the wall of the aorta like rust on a pipe. That plaque erodes. It digs deeper and deeper until it punches through the inner layer and burrows into the middle layer.
Like a pothole that eventually becomes a sinkhole.
Perfect analogy.
Yeah.
And just like the others, once that integrity is breached, the wall can blow out. The scary thing about these three siblings, dissection, hematoma, and ulcer, is that they are dynamic.
May change over time.
A patient can come in with an ulcer, and 3 hours later on a repeat scan, it has turned into a dissection. They evolve.
Which brings us back to the ER. You have a patient with one of these ticking time bombs. How do they present? Because if I open a medical textbook, it says they'll complain of tearing or ripping pain that radiates to the back.
Right. That's the board exam answer. If you are taking a test and the question says tearing pain radiating to the scapula, the answer is aortic dissection.
But in the real world?
It's rarely that clean. Tearing is a very specific adjective. A lot of patients just say it hurts. Badly. The worst pain of my life.
But then you have the outliers. The data from the big international registry shows that about 4.5% of patients deny having any pain at all.
Yeah.
That is the part that terrifies me. No pain. How can you have your main artery ripping apart and feel no pain?
Painless dissection.
Well,
It happens. It's the silent presentation. Maybe they're elderly and their pain perception is blunted.
okay.
Maybe the dissection caused a stroke immediately, so they come in unable to speak. Or maybe they just present with syncope. They just fainted.
Fainting is a huge red flag in this context, isn't it?
Massive. If an older person faints and has chest pain, or just faints for no clear reason, you have to think about the aorta. Maybe the dissection momentarily blocked blood flow to the brain. Or maybe they ruptured into the pericardium, the sac around the heart, and dropped their blood pressure.
So we have a condition that kills quickly, looks like heartburn, sometimes doesn't hurt at all, and hides behind other symptoms. And on top of that, you have to distinguish it from the other two members of the big three. We mentioned them briefly: heart attack and pulmonary embolism.
The diagnostic triad of doom.
Let's clarify the difference, because to a layperson, chest pain is just chest pain. But mechanically, they are very different.
Sure, let's break it down. An acute myocardial infarction, a heart attack, is a plumbing problem in the heart's own fuel lines. A coronary artery gets blocked, usually by a clot on top of plaque.
And the muscle dies.
Muscle dies. That pain is usually pressure, squeezing, an elephant on my chest.
Okay. And pulmonary embolism, or PE?
That's a clot that traveled from the legs. A DVT up to the lungs. It blocks the blood flow into the lungs. That pain is typically sharp and pleuritic.
Meaning it hurts to breathe.
It stabs you when you take a deep breath.
So, in a perfect world, elephant on chest equals heart attack. Stabbing breath equals PE. Ripping back pain equals aorta.
In a perfect world, yes. But the human body loves to break rules.
Of course.
You can have a dissection that feels like pressure. You can have a heart attack that feels sharp. And here is the nightmare scenario. An aortic dissection involving the ascending aorta can actually cause a heart attack.
Wait, how does that work?
If the dissection pair extends down toward the heart, the flap of loose tissue can flop over the opening of the coronary artery like a trapdoor.
Oh, no.
So the patient is having a massive heart attack. Their ECG shows a heart attack, but the cause is a dissection.
And if you treat that patient for a heart attack...
You kill them.
Whoa.
Standard treatment for heart attack is antiplatelets, heparin, aspirin blood thinners. If you give powerful blood thinners to someone who is actively bleeding into the wall of their aorta, you are pouring gasoline on a fire. You will cause a rupture.
That creates this incredible tension. You have to be fast, but you have to be right, because the treatment for condition A is fatal for condition B.
Which is why we call it a minefield.
Yeah.
And we haven't even talked about the imposters yet.
Right, the noise. Because for every one dissection, you have 100 people with benign stuff. I was looking at the list of mimics in the review. Gastroesophageal reflux,
GERD.
musculoskeletal pain, anxiety.
It's huge. Reflux can feel like burning, indistinguishable from angina. Costochondritis, inflammation of the rib cartilage, can be sharp and mimic a PE.
And shingles.
Shingles. Before the rash appears, the virus inflames the nerve, causing a band of intense chest pain that can confuse even the best doctors.
So relying on how it feels is dangerous. We need more data. We need to look at who the patient is. This is where risk stratification comes in.
History's everything. You have to be a detective about the patient's past.
What are the biggest clues for the aorta specifically?
High blood pressure, hypertension. In the data we have, chronic hypertension was present in something like 86% of patients who developed aortic dissection.
That makes sense physically. If you overinflate a tire every day for 20 years, eventually the wall weakens.
Precisely. It's mechanical fatigue. The aorta loses its elasticity. So if a patient walks in with chest pain and tells me, "Doc, I've been on 3 blood pressure meds for 10 years and I skip them sometimes," my antennae go way up.
What else?
Connective tissue disorders. We mentioned Marfan syndrome and Ehlers-Danlos. These are genetic conditions where the collagen, the glue that holds your body together, is defective.
So their aorta is structurally weaker from birth.
Right. A 30-year-old with chest pain is usually low risk. Unless they have Marfan's, then they are high risk.
And lifestyle.
Then there's the lifestyle factors. Cocaine use is a big one.
Why cocaine specifically? Is it just the general toxicity?
It's the mechanics. Cocaine causes a massive, instantaneous spike in blood pressure and heart rate. It increases what we call shear stress on the aortic wall. We see dissections in young, healthy people solely because of cocaine use.
It's like hitting the aorta with a hammer.
Exactly like that.
Okay, so we have the risk profile, we have the symptoms, unreliable as they are, but despite knowing all this, we still miss these diagnoses. The paper mentioned a misdiagnosis rate of up to 30% on initial presentation. That is staggeringly high.
It is, and it's because the initial test can be so misleading. A chest x-ray, often normal, an ECG, might show non-specific changes or even signs of ischemia that lead you down the wrong path toward a heart attack.
So we need a better filter. We need something objective that tells us, stop, look at the aorta, which brings us to the tool belt. And the unexpected hero of this story seems to be D-dimer.
D-dimer is fascinating because it's a test that's been searching for an identity. For years, it was strictly the PE test.
So explain the biology for us. What is D-dimer?
Okay, so D-dimer is a protein fragment. It's basically wreckage. When your body forms a blood clot, it uses a protein called fibrin to create a mesh, like a net, to hold the clot together. Eventually, your body tries to break that clot down using enzymes. When it chops up that fibrin mesh, the leftover pieces are D-dimers.
So if I have high D-dimer in my blood, it means my body is actively breaking down clot somewhere.
Correct. It implies there is clot formation and clot lysis breakdown happening simultaneously.
Now, for a pulmonary embolism, this makes perfect sense. It's a giant blood clot. But for an aortic dissection, that's a tear? Why does a tear cause high D-dimer?
This is the key. Remember the false lumen, that pocket of blood inside the wall?
Yeah.
The blood in there isn't flowing smoothly. It's turbulent. It's stagnant. It's hitting the raw, injured tissue of the aortic wall. That injury triggers the coagulation cascade. The body thinks, I'm bleeding. I need to clot. So that massive false lumen becomes lined with clot.
I see. So it's not just a tear. It's a massive surface area of clotting blood.
Exactly. And because a dissection can be huge, it can run from your neck to your legs.
Yeah.
The amount of clot burden is massive. Therefore, the D-dimer levels skyrocket.
Okay, let's look at the numbers from that et al. Study. They took nearly 800 patients coming into the ER with chest pain. They compared the D-dimer levels across the different diagnoses.
And the difference was stark. The median D-dimer for patients with acute aortic syndrome was around 4.19 micrograms per milliliter.
And for a regular heart attack?
About 0.45.
So nearly 10 times higher.
Right. But, and this is a huge but, the value of D-dimer isn't in finding the high numbers, it's in using the low numbers.
The rule-out concept.
Exactly. In emergency medicine, we love tests that let us say no. If a test has high sensitivity, it means it almost never misses the disease. So if the test is negative, you can be pretty sure the disease is absent.
And the sensitivity here was high.
Incredibly high. The study found that if you use a cutoff of 0.5, the sensitivity for ruling out dissection was around 94 to 97%.
So I come in with chest pain and my D-dimer is 0.2.
You can be reasonably confident, 97% confident, that you do not have an aortic dissection. You might have a heart attack or reflux, but your aorta is likely intact.
That's powerful. That saves me from a CT scan. It saves me from radiation. It saves the hospital resources.
But now we have to flip the coin. What if the D-dimer is high, say it's 2.5? Does that mean I have a dissection?
Not necessarily. It could be a PE.
It could be a PE. It could be that you're pregnant. It could be that you have cancer. It could be that you have an infection. Or honestly, it could be that you're 85 years old. D-dimer naturally rises with age.
Ah, the specificity problem. It's a sensitive alarm, but it goes off for everything.
Exactly. A high D-dimer tells you something is wrong, but not what is wrong. So you're left staring at this high number. Is it the lungs? Is it the aorta? Or is it a massive heart attack that's causing some clotting too?
So we need a second variable to triangulate, and that variable is troponin.
Troponin is the gold standard for the heart. It's a protein found inside heart muscle cells. It should never be in your blood.
Because that means the cells have died.
It means heart muscle cells have burst open and died.
So high troponin easels heart attack.
Usually. But again, biology is messy. If you have a massive PE, your heart is straining to pump against that clot. That strain can leak a little troponin. If you have a dissection, the sheer stress on the system can leak troponin.
So we have a situation where everything elevates everything slightly. We need clarity. And this is where the new math comes in. The study by Lee et al. They proposed looking at the relationship between these two numbers.
The D-dimer to troponin ratio. The DT ratio. It's brilliant in its simplicity.
Walk us through the logic here.
Okay. Let's take scenario A. The aortic dissection. You have a massive false lumen, tons of clot. So your D-dimer is very high.
Right.
Unless the dissection's blocked a coronary artery, your heart muscle is mostly fine. So your troponin is low or normal. Big number divided by small number equals.
A very big number, a high ratio.
Correct. Now, scenario B, the heart attack and an STEMI. You have a blocked coronary artery, lots of dead muscle. So troponin is very high. The clot in the heart is tiny compared to a dissection. So D-dimer is low or normal. Small number divided by big number equals.
A tiny number, a low ratio.
So the ratio amplifies the signal. It pulls the two conditions apart mathematically.
Did they find a magic number? A cutoff where the decision changes?
They did. In their data set, the cutoff was 81.3.
That's very specific.
It is. If the ratio was greater than 81.3, it predicted acute aortic syndrome with a sensitivity of over 91% and, crucially, a specificity of 96%.
Wow. That specificity is the game changer.
It is.
That means if the ratio is high, it is very likely to be the aorta. It filters out the noise from other conditions.
It creates a shortcut for the physician's brain. You have a patient with confusing symptoms. Both tests are positive. You plug them into the calculator. If the result is 5, you focus on the heart. Call the cardiologist.
And if it's 200?
If the result is 200, you focus on the aorta. Sprint to the CT scanner.
It effectively deconflicts the signal. But what about PE? Doesn't PE also have high D-dimer?
It does. And that's the tricky middle ground. PE will also have a high ratio because D-dimer is high and troponin is usually low. But clinically, PE often looks different. More shortness of breath, lower oxygen levels. The ratio is primarily helping us distinguish vascular catastrophes like aorta or lung issues from heart muscle catastrophes like an MI.
Okay, so we have these biomarkers, we have the math, but you can't just practice medicine by calculator. You need a framework, a safety net.
Right. You don't just treat the number, you treat the patient. This brings us to clinical decision rules. These are structured checklists that help doctors avoid relying on gut feeling, which is often wrong.
For the aorta, the big one mentioned is the ADDRS.
The aortic dissection detection risk score. It sounds fancy, but it's really just digitizing what we discussed earlier. It assigns points in 3 categories.
Break them down.
Category 1, high-risk conditions. Do they have Marfan's? Do they have a family history? Do they have a known aortic valve defect? If yes, you get a point.
Okay, category 2.
High-risk pain features. Is the pain abrupt? Is it ripping or tearing? Is it migrating, moving around? If yes, point.
And category 3?
High-risk exam. This is where the physical exam matters. Do they have a pulse deficit?
Explain that one.
If the dissection tears down the aorta, it might block the artery going to the left arm, but not the right, so you feel the pulses. The right arm is booming, the left arm is dead. Or the blood pressure is 150 on the right and 90 on the left.
A big difference.
That is a massive red flag. You get a point.
So you sum up these points, how does this combine with the D-dimer?
This is the integrated strategy. If the ADDRS is low, say 0 or 1 point, and the D-dimer is negative, so below 0.5.
You are safe.
The statistical probability of a dissection is close to 0. We're talking like 0.3%. You do not scan this patient. You look for reflux or muscle strain.
But if the score is high, so greater than 1, or R if the D-dimer is positive.
You scan. You go straight to CT angiography.
It sounds so orderly. Logic gates. If this, then that. But we all know the ER is the place where logic sometimes goes to die.
Enter the black swan.
We have to talk about this case study by Jacob et al. From 2024. I read this and my jaw hit the floor. This is the ultimate medical nightmare.
It really is. It illustrates why, despite all these rules and ratios, you eventually need human experts in a room making impossible choices.
Set the scene for us.
So you have a 77-year-old man who arrives at the hospital. He's been in a car accident, head-on collision.
Okay.
He's conscious. His vitals are initially stable. He has some right-sided chest pain, but hey, he just hit a steering wheel. He has broken ribs.
So far, this looks like a standard trauma case. Admit to ICU for observation, pain control. Done.
Right, but 2 hours later, the turn. He suddenly develops crushing left-sided chest pain. Not the rib pain, new pain. He gets sweaty diaphoresis, his blood pressure crashes, he becomes hypotensive, and his oxygen levels drop.
The patient is crashing, the doctors scramble. What do the tests show?
They run the labs we just talked about.
Yeah.
His troponin, it was 7 on admission, now it's over 1,700.
Yeah.
His ECG, it shows ST elevation in the anterior leads. The tombstone pattern.
That's a STEMI, a massive heart attack.
It's a heart attack. The LAD artery, the widowmaker, is blocked. So the protocol says, get him to the cath lab immediately, give him aspirin, give him heparin, blast that clot open.
But they didn't do that immediately. Why?
Because he was a trauma patient. They had done a CT scan earlier for the car crash. And that scan showed something terrifying. He had a type B aortic dissection in his descending aorta.
Oh, no.
And because his oxygen dropped, they looked at his lungs. He also had a pulmonary embolism in the left upper lobe.
Wait, pause. He has a massive heart attack, an aortic dissection, and a pulmonary embolism at the same time.
And a pneumothorax, a collapsed lung from the broken ribs. He is the big 3 plus a collapsed lung.
Yeah.
All simultaneously.
How is that even possible? Did the car crash cause them all?
It's hard to say. The trauma likely caused the dissection and the pneumothorax. The stress of the trauma might have ruptured a plaque in his heart, causing the STEMI, the PE. Maybe he was already there, or formed from the stasis after the crash. It's a perfect storm.
Okay, let's look at the treatment dilemma here. This is why I called it a nightmare. You have a STEMI and a PE. Both require anticoagulation. You need to thin the blood.
Correct. If you don't open that coronary artery, his heart stops. If you don't treat the PE, he can't breathe. That's the immediate threat.
But he has an aortic dissection.
And the number one rule of aortic dissection is do not anticoagulate. If you thin the blood, the dissection can extend. It can rupture. If it ruptures, he dies instantly.
It's the ultimate rock in a hard place. Option A, treat the heart and lungs, risk blowing up the aorta. Option B, protect the aorta, let the heart die.
And don't forget the pneumothorax. That needs a chest tube, a plastic tube shoved through the ribs to re-expand the lung. But putting a large bore tube into a patient on blood thinners, that's a massive bleeding risk too.
This feels unsolvable. An algorithm would crash here. The ADDRS score can't help you here. What did they do?
They convened a heart team. This is the gold standard for complex cases. They got the interventional cardiologist, the vascular surgeon, the radiologist, and the trauma team in one room. They had to weigh the immediate risks.
Who is killing him fastest?
The hypotension and the ECG changes said the heart attack was the immediate threat. The heart was failing now.
And the dissection.
The dissection was a type B. Remember, the type A is the ascending aorta that needs surgery immediately. Type B is the descending aorta. It can often be managed medically with blood pressure control. It looks stable on the CT.
So they made a calculated bet.
They bet that the aorta would hold. They decided to treat the STEMI. They took him to the cath lab. They gave him heparin. the very drug that could kill his aorta.
Wow.
They put a stent in his LED artery to restore blood flow.
That takes nerves of steel.
It does. They treated the PE with the anticoagulation as well. They put in a chest tube for the lung,
Oh,
and they watched his aorta like a hawk on repeat imaging. The gamble paid off. The stent saved his heart. The heparin cleared the PE. The aorta did not rupture. He was discharged 15 days later.
that is incredible.
It really highlights that while we spend all this time talking about D-dimer cutoffs and ratios, which are vital for the 95% of cases, medicine ultimately comes down to judgment. It comes down to weighing imperfect options in the face of uncertainty.
It's managing chaos. Now, before we wrap up, we need to bring the audience back down to earth. We've been hyping up D-dimer and this ratio, but we have to talk about the limitations.
Yes.
Where do these tools fail?
Great point. We don't want listeners thinking D-dimer is magic. First, time matters. D-dimer is most sensitive within the first 24 hours. If a patient had a dissection 3 days ago and has been sitting at home and finally comes in, their D-dimer might have washed out.
It creates a false negative?
It can, yeah. So don't trust a normal D-dimer in a delayed presentation.
Okay, what else?
Second, the type of ADS matters. Remember the siblings, the intramural hematoma and penetrating ulcer.
The bruise and the pothole.
Right, because IMH is a bruise inside the wall, it's contained. There isn't always that massive flow of fresh blood washing over the clot like there is in a full dissection. So D-dimer levels can be lower or even normal in IMH and PAU.
That is a critical blind spot. A normal D-dimer does not perfectly rule out those two subtypes.
Correct. If the clinical picture screams aorta, but the D-dimer is normal, you might still need that CT scan to catch an IMH. Also, really short dissections, or ones where the false lumen is completely clotted off, can have a false negative D-dimer.
And what about the ratio? Where does that go wrong?
The ratio relies on the kidneys working properly. Both D-dimer and troponin are cleared from the body by your kidneys. If a patient has renal failure, which is common in older, sick patients, their baseline levels of both proteins are going to be weirdly high.
So the math breaks down because the denominator and numerator are artificially inflated.
Exactly. Also, chronic aortic disease, like an old aneurysm, can keep D-dimer chronically elevated. So in those complex patients, the simple cutoff of 81.3 might not apply. Context is everything.
So, bringing it all home, we've covered anatomy, biochemistry, math, and a wild case study. What are the big takeaways for the listener today?
I think there are 4 key points to put in your pocket. Number 1, chest pain is a minefield. The big 3 mimic each other, and as we saw, they can even happen at the same time. Never assume it's just heartburn without thinking twice.
Number 2,
acute aortic syndrome is rare, but it is the silent killer. Don't rely on tearing pain alone. Look for the risk factors. Hypertension is king. Look for the pulse deficits on exam.
Number 3, the tools.
D-dimer is not just for lungs. A level below 0.5 effectively rules out dissection in low-risk patients. It's a powerful stop sign.
And finally, number 4.
Check the ratio. If you have a high D-dimer and a low troponin, so that DT ratio is over 81, stop looking at the heart and start looking at the aorta.
It's a shift in mindset.
It is. Medicine is moving away from scan everyone, which is lazy, and exposes patients to radiation towards smart testing. We are using biomarkers and math to find the signal in the noise. It's better for the patient, and it's better medicine.
It's a fascinating look at how we're getting better at catching the invisible. Next time you hear someone say, "I have chest pain," you'll know just how much calculation is going on behind the scenes to keep them safe.
And hopefully, you'll appreciate the detectives in the white coats sweating over those numbers.
Thanks for listening to The Deep Dive. We'll see you next time.
Take care.